Hello, the doctor is in. We are here today. The doctor is in. Hey, Mo.
Hey, Ricky, the doctor is in and the doctor is tired. Can I just tell you that I love t-shirts that have messages. Like I love message clothing. And this particular shirt I'm wearing is a shirt made by one of my sorority sisters. And she has a business called Henderson Calms. She's a life coach and a therapist. And it says naps, facials, pedicures, manicures, going to therapy, saying no to burnout. Self-care matters. Live a life of calm. And I don't know about you guys, but I'm just feeling it today. We're in April already.
Right.
And it's a lot going on. So I wanted us to talk a little bit about that and honor that before we get into the subject that is very familiar to us, which of course is Black breast cancer. And we need to talk about that, especially this month. But we do have a great guest with us, no stranger to us.
We do. Our breastie.
Yeah.
Yay.
Thank
you for having me.
Fire.
Our rockstar breastie.
Somebody asked me about you, and I said she's a complete disruptor to the cancer advocacy game. That was my statement about you.
Thank you.
We just
I
said
appreciate that.
that.
I'll take that.
We can't do anything with the status quo anymore. The status quo is not working, and
not at all.
And we've got to change it. We've got to be game changers, and we can't. It's like, the word insanity, doing the same thing over and over and over again, getting the same bad result. The stuff is not working. So
yeah, and that complacency. And I think I hear it all the time where people tell me, well, it's just going to be impossible. And, when they hear about the work that we're doing, and I'm just like, you know what? I'm motivated by the lives that we're impacting. One cancer center, one clinical trial, one woman at a time.
You know what, Jamil? When I see the word impossible, I am possible.
Yes.
That's it. Would you give us your introduction for people who are newly joining us and who don't know what a badass you are?
Yeah.
That means a lot coming from y'all. Y'all gonna make me all sentimental and emotional up in here.
It's all up.
I am Jamil Rivers. I am living with metastatic breast cancer. I was diagnosed in 2018. I'm a married mom of 3 boys, all boys. And I am also the founder and CEO of the Chrysalis Initiative. So the Chrysalis Initiative was born out of my own personal experience, navigating through my breast cancer journey, also getting involved with advocacy early on and learning as much as I possibly could, just motivated by my family, married to a 2-time cancer survivor already, trying to learn as much as I could about breast cancer and noticing as I'm involved as an advocate and joining all these organizations. I'm the board president also of Mediviver. I'm on the board of directors of Living Beyond Breast Cancer. I am a metastatic advisory committee member and advocate in science and policy advocate with Susan G. Komen. And so really involved and plugged in as far as, all of the areas where there should be improvement in this space. And I was just taken aback and shocked by the fact that Black women are dying from breast cancer at a 40% higher rate. And I would always hear the narrative was, well, it's just nothing we can really do about it. It's just due to socioeconomic status and social determinants of health and comorbidities and the distrust of Black people in clinical trials and the low percentage of Black women participating in clinical trials. I do think that all of those are contributing factors, but that's not the end all be all. And the largest contributing factor, I think that is the elephant in the room that nobody wants to deal with, is the underlying systemic bias and racism in the care setting. And that was my experience with the women that we're helping with the Chrysalis Initiative, meaning that Black women are not receiving quality care just due to bias, because someone has the autonomy to cause harm to that patient because they're operating in a silo. There's no check and balance in place to ensure that their bias is not impacting that patient's care. And so as a disruptor with the Chrysalis Initiative, we're working with cancer centers, one cancer center at a time, to show them how to provide equitable care, to acknowledge that bias and racism exist and how to address that. And then also making sure that those patients are protected and empowered. So ensuring that they have the information that they need and the support and reinforcement that they need so that they're not impacted by somebody else's bias that's trying to take them out.
Mhm.
Yeah, and
So,
it's really a position of privilege.
Hmm.
And I think this is just so deeply rooted, and so much of this has gone on for so long that
Yes.
it's accepted as status quo. It's accepted
Yeah.
as the way things happen until somebody peels back the onion.
Yeah.
And so I love that you are taking it on. And one of the really only good things about COVID is that at least this stuff is now on the table, and we're
Yes.
coming into this conversation where people are asking the right questions and or asking the questions, maybe not the right ones, but asking the questions, and at least trying to open the door to a conversation. Now, are they
Yeah.
listening? I don't know. Are they really going to act on it? I don't know. But that's why we have to pound the pavement and fight this fight every day, because we have to hold people accountable. and
Yeah.
and I think that what your training thing, which I want to explain everything you're doing, because there's so many things, so many layers, but that's
Hmm.
where if you're teaching the people that are touching the patients and teaching the people that are dealing with the day-to-day issues of what patients are really dealing with, that's where you can make a difference. It's not at the top. It's not even at the doctor's office. Well, I mean, at the head doctor office. It's really the people that
The
are
system.
the system that's working with the people. So
Yeah.
talk about it, like break it down for the 6-year-old.
Okay. Yeah. I mean, really, if you think about it, cancer is already trying to take you out and kill you. The only thing that we're saying is don't allow your racism and bias to aid and abet the breast cancer from killing me. Meaning that I need to have all systems on deck and make sure that I have all the information needed. So when you just think about standard of care, I'm a Black woman, I go to the cancer center, I present with symptoms, I have a lump. I should be able to be seen, screened, have that diagnostic workup, even if I'm under the age of 40, in order to assess whether or not if I have a breast cancer diagnosis, right? But a lot of times Black women are turned away. So that's already a delay, and causing potentially, on this whole continuum, of being diagnosed and receiving that treatment, that delay is potentially going to make me more vulnerable to disparities, where I'm now going to have a higher likelihood of adverse outcome later. So just thinking about that presentation of symptoms, getting that diagnostic workup, am I getting standard of care? So meaning so say if I get past that stage and I'm able to start getting that diagnostic workup, am I getting, the actual testing that I should receive based off of my specific characteristics? So of course, that is the biopsy and the mammogram and, the imaging and the blood test, and also potentially genomic testing. We find that many Black women are not even offered genomic testing or genetic testing. So
Right.
meaning if this is something that can determine how specific and targeted my breast cancer treatment should be and how likely I will have a durable response to my treatment, it should be a given. It shouldn't be assumed that because I'm a Black woman that I can't afford this particular test, or I don't have the insurance coverage for this particular test, or that even if a clinical trial is the best option for me, that I'm just not going to participate. But we have a lot of um, bad actors that are functioning as gatekeepers in a
Mhm.
sense. So they're making assumptions about what I look like. So if I have highlights in my hair, or I might be, a single mom, or they might think that my attitude is hostile or intimidating to them. That now gives you the autonomy to just decide, I'm just not going to share that information with that patient, which could potentially determine my outcome on my continuum of care and what, my survival could
Right.
potentially be.
Right.
And so the whole way to disrupt that system is to, one, have visibility and accountability in that space. So meaning if you are one of these NCI, NCCN centers, or even a community-based center, where this is important to you to address those disparities, we provide, here are all the areas that you can look and unpack and do a deeper dive to understand this is where that disparities and that bias lies, where you need to look at that and then actually assess whether or not if that's what's going on here, as to what's causing this disparity in this area. And then that will tell you how you can create that accountability and visibility in this area so that these healthcare professionals can't just cause harm to these patients without any type of accountability. And in the meantime, as we're doing that, we're protecting the patients and empowering them with information so that they know what tests to ask for, what that quality treatment should be like, what they should understand about their particular type of breast cancer and what treatment should be offered to them. And that really just takes off that fogginess. It really enlightens them as to what I should know and expect. And it totally changes the game as far as their survival outcomes. So meaning they're now on an equal playing field, which I consider myself to be the equalizer, like Queen Latifah. We're now
All right.
we're now equalizing where they're not impacted by disparities now because they have that information. They're empowered to know what they need to ask for and expect and demand and advocate for themselves. Meaning, I'm going to you for care. I need to have all of this, and it should not just be determined by someone's assumptions or implicit bias about me because you're not recognizing my humanity. And so it's not all hands on deck when it comes to my survival, but I am someone else's mother, sister, daughter, friend, and my life matters too.
Right.
I got to jump in here. I got to jump in on a couple things because I think that so much of what you've said is it's very true and it's accurate, but I think it also represents one very, I'm going to call it one very actionable part of a larger picture, right? So when you talk about the concept of structural racism, which is that the structures that are in place that were not created by the current generation of doctors, you see, were not created by the current generation of non-Black and brown people that are here, but the systems that are in place to systemically oppress us, of which medicine and healthcare is a part of that structure, right? Was not created by these doctors who are trying to operate within this structure now. And it is very challenging, I think, to even teach students about that because you already feel like you're trying to wrap your mind around a diagnosis of this or that. And then to figure, how do I change the whole structure of healthcare such that it is now an equal playing field? Is it's overwhelming. And I'm not saying this in any context of defending healthcare because I don't think it needs defense. I think it needs repair. But I think that what you've done is you've honed in on a place where we can start. And, you know, I guess the question is for you, and it's how do you take the model of one cancer center at a time, one patient at a time? How do we amplify this to make systemic change? And one thing you said, well, look at the NCI designated centers. Majority of cancer patients, Black and brown patients, don't get care at NCI designated centers.
Explain what that is to our audience.
So the NCI is a national comprehensive, is a National Cancer Institute. It is the federal agency that regulates the quality of cancer care, right? And you can only be a designated center if you meet certain criteria, like having research, having fellowship trained specialists, having all the different components of a cancer center, significant funding from the government and other things. So you got to go through a lot of hoops and hurdles to be an NCI designated cancer center. There are probably
people go to those?
Huh?
Black people go.
No, they do.
Black people do go to those. So here in Philadelphia, you've got Fox Chase Cancer Center, you got Penn Medicine, you've got Jefferson. There's 3 of them in the city of Philadelphia.
Okay.
But there's also the Einsteins, the Abingtons, the Grandview Health, the places where people, you know, get their care. 80% of people get their care community hospitals.
Yes.
So there's an opportunity and a challenge there. And next, I want to get to, after we cover this, is the responsibility of the patient. Because I tell you, you know, of the 4 Black women that I saw this week so far, 3 of them sat there like this as I tried to explain it in the urgency of even getting a biopsy. And one of them accused me of harassing her and stormed out of the office. And so then the 5th patient comes in and I told my staff, I said, watch this. I said, because you've all been affected. And you're like, okay, here comes this patient. She's going to be combative. She's going to be this. She was lovely. She was receptive. She was, you know, asking great and intelligent questions. And the chances for bias are so prevalent and so there that it's not like every patient comes to the table ready for treatment. They don't all do that. They're not all Jamils. They're not all Rickies. They don't all want to take the bull by the horns.
And fix it.
I got so much to respond there.
So 2 things we got to talk about. 1, how do we amplify your message to community centers? And then 2, what is the responsibility of the patient, of the person who, you know, is trying to take all this in? And how do you get to the point of acceptance and empowerment?
Yeah. All right. Let me add one more question to that. The woman who knows nothing, who doesn't
Yeah.
even know that she's being discriminated against because she just doesn't know,
Exactly. Yeah.
right?
Nope.
That's who I want to talk. Like, where is she in all this? So
Yeah.
go ahead,
Oh, yeah.
your
So,
boss.
all right. So the reason why I mentioned the NCI centers is because there's considered to be the creme of the crop. This is like, the center that you should go to for that high quality care, right? But yet we still have these bad actors being able to do this at these centers that I say claiming want to address disparities and are talking about, it's so important to them. However, if that's the case, why is there no accountability? And this can happen with no checks and balances in place. So that's what I'm referring to when I talk about that this can happen in an NCI center, knowing that the majority of our patients are receiving their care at community-based centers that are not NCI designated, but just wanted to show that even with all these accreditations and scorecards and certifications and compliance, that this can happen without any type of accountability. And so we're disrupting that, meaning that this is how you can ensure there's that visibility and accountability in these areas so that the patient isn't harmed in that regard. And you're exactly right. I think that there are those assumptions about patients that come in. I am an assertive patient. So from the gate, I was saying, well, I've done my research. I need this, I need that, I need that. But I also remember how I felt that first day when I found out that I had stage 4 breast cancer. So overwhelmed, alone, and feeling like my kids are not going to have a mother. So remembering that desperation and isolation and feeling overwhelmed, I was able to kind of hunker down and get it together. However, so many people are never able to get out of that space.
Right.
And so makes me so proud about the coaching that we're offering is because the early on that we can really be involved and engage with that patient from the beginning, as early as that diagnosis that you're talking about, Ricky, meaning, she just learned she has breast cancer. She's less vulnerable to be impacted by the bias and racism because she's going to know what that high quality care is supposed to feel and look like, and so based off of our care tracker and how we're saying, okay, this is, you now have a coach that you're matched with to basically make sure that you get all the care that you are supposed to receive. We will get as much in your business as you allow us to. So we will tell you what questions you should ask and what you should expect. And if there's any delays there, or if there are any issues that, could be a red flag that you might be susceptible to a care provider that is exhibiting bias. And so how do you navigate through that, and what additional options can you move forward with in order to make sure that you get the best care in order to manage your breast cancer and treat it properly? And so that's like our biggest, we are matched with patients no matter where they are on this continuum, but the earlier the better. So that way that they're empowered with that information as soon as possible. Also, I also say to health systems that we can't have it both ways. You can't say that patients are uneducated, not engaged in their care, don't care, not going to be compliant with the instructions that the doctors are given, and say that, that's just a reason for these disparities. But then on the other hand, put the burden on the patient and say that they have to be a project manager / paralegal to chase down the 17 different individuals that has been clocked as the equivalent of what our coaches offer, meaning a patient would have to chase down 17 different individuals in order to get that supportive resources and care that, we're offering in one coach. So it's already enough, meaning Black women, we already have a lot on our plate. We're typically the head of the household, taking care of children and elders. And then now we have breast cancer. And now you're saying that I have to be a project manager and paralegal damn near to chase down all these individuals in order to make sure that I get the best care that I can get and educate myself on the level of a clinician to understand what care that I should receive. So I think that there has to be some accountability there where it can't be both ways. You can't have both sides. So, there has to be that emphasis to not make assumptions and really have that part of your cancer care. So meaning we teach health systems how to replicate what we offer with our coaching model to say, if you're going to, the patient navigation piece is almost just as important as the treatment itself. So meaning in order for them to receive that treatment and adhere to it, they need to be able to stay on it. And
Right.
so the way that you do that is providing those resources to them to deal with that. And, it's just as important. You have to tailor and assess those needs based off of the individual. And it's a high bar, but it really is simple when it's not overwhelming and just too much when you really take the time to think about what are the needs of that patient and have it customized to them where they can receive the information. You are staying engaged with them and just ensuring that they're able to receive that care. And then also knowing about owning up to, you might have your own biases. We all have them. How to communicate where that patient-clinician communication is solid, pulling in additional team members if you need to, or pulling in the Chrysalis Initiative if you need to make sure that communication is solid so that the patient is receiving what they need to understand and that there aren't those breakdowns, because we find a lot of times the clinician, the HCP, the oncologist, the nurse practitioner, the nurse navigator, they'll just break down. So meaning this Black woman is hostile, she's not paying attention to me, she's not, I guess, the personality type
Right.
is not, enough deference. So meaning, because I feel intimidated or I feel disrespected or if I'm not given as much reverence as I think that I should receive, I don't believe she's deserving of all hands on deck that I would give to other, patients. And
Right.
some people will describe that as, well, it's just circumstantial. You connect with other patients more so than others, and that's just how it is. But again, we're not in the high school cafeteria. If you're providing substandard care to a Black woman, your bias should not get in the way of that. She should be able to receive quality care without your racism getting in the way. And that is racism. When your bias is contributing to that patient not receiving quality care, that's racism. So racism doesn't just always have to be you calling me the N-word or punching me in the face or any of that. It could be you have not recognized my humanity. And so for you,
Right.
it doesn't even register that you need to provide that care at the same level as that white woman that came to see you as well.
Wow. And there are tools to help anybody who's interested in understanding what their biases are. I do a lot of unconscious bias and trainings on blind spots, and Harvard has a test. I'll put the link in the chat for people who are interested, but there is an implicit association test that you and anyone else can take. And I love to do it with cohorts and groups, because individually people do it and they don't necessarily like to see, where they fall, because this test tests your implicit bias for things like skin color, obesity, right? Race, gender. There's one for like facial features, slanty eyes versus beards versus whatever, and there's so many different categories across which you can see where you have a bias. And when you do it with a group, you really get to see, because the results are anonymous, but they batch them all together. 86% of people had a bias against fat people, right? Had a bias against brown people or against women or whatever the categories. So then you can see that it really is real. And you have a launching pad for it, but something you said really resonated with me, which is that when there is the transparency and the accountability, things can change. And I think that is the key. And we need to spend some time educating patients on what the standard of care is, because if you don't know, then you will just go to your doctor and they'll say, okay, the doctor said I need XYZ. And you may either agree or disagree, but you won't know what the standard, what the guide is. And the NCCN guidelines, the cancer guidelines, they're very confusing for patients. Like we need to come up with an NCCN for dummies or something, like not even for dummies, but just for the average person, because it's like reading a treasure map or road map. If this, then this, then this, and go here and go there. It's hard for doctors to read.
Yeah.
We need that kind of roadmap for really everything in healthcare, because people just don't know what to do. They don't read it, or they can't read it, or they don't want to read it, and they can't get there, So
another important point is that our coaches are really highly trained patient advocates. So meaning, it's not, I do feel that in the breast cancer landscape, that connection typically with other breast cancer survivors has been limited to, hey, I went through breast cancer, so did I. And it's just kind of like that social support. But our coaches are actually highly knowledgeable about breast cancer, and continue to get ongoing training and education on breast cancer and the science of breast cancer and all the new treatments and innovations and everything that you can learn as an advocate at all the various resources, such as San Antonio Breast Cancer Symposium. And we find there's a lot of innovation, there's a lot of new treatments, a lot of new developments that these community-based oncologists are just not privy to. And so we're able to provide that information and really empower, patients to go to their doctor and say, hey, well, I need to have this test and we need to check this. And this marker is an indication of this. And this could make me a good candidate for this particular treatment, because you want that to be as targeted and specific as possible when it comes to their treatment.
You want it to be targeted, but you want it to be relevant.
So how do we even get from just give me the standard of care and explain it in language I can understand to things like clinical trials?
Well, what we find is with our coaching, since we're, making sure that each patient is consistent with that Chrysalis care tracker, that clinical trials is really just an additional aspect because it's related to treatment. So we don't actually make it a point to encourage Black women to participate in clinical trials, but we find that the data shows because of this relationship with their coach and that wraparound reinforcement and support that they're getting, they're more inclined to participate and seek out a clinical trial, or more confident to seek it out and ask about it, more inclined to stay with it and adhere to it, because we're helping them navigate through all the, navigate all of the questions and who do I go to, and helping them draft emails to ask those questions, or how do I deal with this particular side effect, or even just the financial toxicity or insurance questions, meaning because they have that support and they have that one-on-one matchup, they really have in the palm of their hand through the phone and then later on the app, that connection to have that resource to let them know as much as they need to make sure that they get the best care possible.
That's great. I think part of it though is like, how do you get them to know that they need to know something? There's grounds.
Well, a lot of times it's just a conversation. So I think I was talking about yesterday about a new enrollee that we had, and just having, as we're just getting to know our new participants and understanding the challenges that they're going through. And a lot of times, if they're not aware of a solution to that particular challenge, they'll just muddle through and they're just kind of accepting, oh, this is kind of how it has to be. But if it's a side effect challenge or to a particular treatment, or if they're having financial toxicity, we'll say, typically we try to focus on the supportive service that are already available within that cancer center that they may not be knowledgeable about. So we are knowledgeable about what that particular cancer center offers. And so we'll say, well, hey, did you check into these resources at your cancer center that are available? And yesterday, the patient said she wasn't even aware that they had that program at the hospital to provide that support with the insurance issues that she was having. And so that's an area where causing challenges with staying on top of her treatment, and because financial toxicity is a barrier to receive treatment, and then having that resolved and having us be that bridge to resolve that issue now just takes that away. It's not that barrier lingering there anymore. And that's just an easy example of an easy solution where she just wasn't even aware that that was available at her cancer center. And that's a whole nother conversation about why was she not aware?
Right. But
True,
what a blessing you're providing. You're providing such a blessing, to help people get what they need and understand what they're missing potentially.
Exactly.
Even for our cancer program, community cancer program, we have one financial navigator, and we had to do an awful lot of proposals and begging and showing return on investment for our hospital to even get to the point of training this person to begin to do this position, because it's not necessarily a revenue generating position. It does save the
but it is cost
money.
savings.
It saves the
Cost
hospital
savings,
money,
but they don't
and we were able to
recognize that.
demonstrate, and we track it really closely with the health systems and the cancer programs that don't know about this. Like
Yeah.
it has been a real game changer for our patients, because previously I can tell you patients have called my office, or they've shown up to get their port placed, and they come in and they're crying, and I say, what's going on? I know you're afraid. I know, but what, is everything okay? And they said, what, when I get there on Monday, my chemo bill is $10,000.
Mm.
And I have to choose between, 2 months of mortgage, 3 months of mortgage,
Right.
and
Feeding my kids,
chemo,
paying the rent,
paying the rent.
for
Right.
getting treatment.
Right.
And we have so many patients that actually, and this is another key area that I think is important, because we also teach health systems how they need to thought partner.
Right.
So patient navigation is not sufficient enough to just print out some paperwork, put it in a folder, and give it to the patient. So
Yep.
meaning if, and especially Black women, because if you think about us, we don't share our stories traditionally. Even if we have history in our family, we don't have that frame of reference. And so all we know about chemotherapy is what we've seen on TV, or maybe what we heard about. And some of us equivocate chemotherapy to death. So if you tell me that is my only option, right?
Yep.
And so you've provided me with some resources, but that's the whole thing of understanding what motivates that patient and what's keeping them up at night. And I'm sorry, but that has to have a conversation. There has to be some connection there. And we find plenty of times where, what they thought chemotherapy was totally different, where they were ready to check out and just say, well, I don't want to be a burden on my family. I'm not going to be able to work. I'm not going to have any money. So I'm going to go check out some herbs, and I'll have that be my alternative. Those herbs are not going to deal with your cancer. I'm sorry. They might be able to help with some quality of life and side effects, but they're not going to address your cancer. And so it's helpful for them to meet women like me that, yes, I went through chemotherapy. Yes, I lost on my hair. I got my eyebrows tattooed, put a wig on, and I still went to work every day. It is doable. So meaning, if you don't want to work, if you do want to work, don't think that your life has to be over just because you hear the word chemotherapy.
Wow.
But it requires that thought partnering to think about what's possible.
And we know that the data shows that when doctors spend that time with patients, and it really does have to start with the doctor, because when the doctor comes in and gives a diagnosis or talks about a treatment plan, but then has their hand on the doorknob and they're out the door, and then they expect the nurse to do the rest and the navigator to do the rest and the support team, there's not as much uptake. And I think it becomes things that are optional and adjuvant or adjunct, rather than this is what we do for every patient. No, we have wraparound care. We do what are your unique considerations? And that tailored care plan is something that should happen, but doesn't happen nearly enough. Now, let me ask you guys both this question. At what point do we need to start, or where can we start with our communities so that you're not getting this education at the time of your diagnosis? How do we expand this message? Because by the time you get a diagnosis, one, you might have already felt a lump, or you had an abnormal mammogram, so you crap in your pants for the 2-3 days till you get your biopsy, and then the week till the biopsy results come back, and then you see the doctor, and then so you're already here.
Yeah.
And now we're saying, well, now you have to understand these are guidelines, and now you have to navigate it. You know what I mean? Like, and it's great. It's just like everything's hitting you like a ton of bricks. But at what other point in a woman's life can we begin to have this sort of education, so that it's not when you get diagnosed?
Well, we also have our pre-diagnosed programming. So that's really important. Thank you for queuing that up, Dr. Gary.
That's what I'm here for. That is why I'm on your team.
Yes. And so before they even get to a breast cancer diagnosis, it's understanding those aspects of breast health. So, white women, when they go to the OBGYN, they're hearing about genetic testing and their risk and how to have those conversations. So anytime there's an event, especially with Black and brown women, where we're talking about breast health or overall health and cancer prevention, we're just having those conversations. And we also visit schools. So in order to talk about the difference between ovarian cancer or breast cancer and brain cancer. So meaning, was that actually brain cancer that your grandmom perished from, or was it breast cancer that traveled to the brain?
Right.
And even just the difference between diabetes and breast cancer and pneumonia and leukemia and all these different ailments, but understand what that family history means and how to ask those questions. And we even have the role playing where, how do you ask your aunt during the movie, during Netflix, you know,
Yeah. Play it out with the-
how did so and so, you know, what I need to know, what stage was it that she was diagnosed? What type of cancer
wait.
was it?
Rewind.
What was
If
the
you said
treatment?
this is during the Netflix, during the movie.
Yes. You know, or just bringing it up, you
Love
know, genealogy, you know, family reunions, those opportunities to talk about that, you know, to know, okay, they ended up, but you have to know their family history and how to, you know, and I'm telling you, I deal with this in my own family. They push back quick when you start asking those type of questions.
Business, right?
But
That's your
you
business.
have
a lot
to
of
know.
suspicion. Yeah.
You
Right.
have to know. And so really just say, and I think if you implore them to say, well, I don't want to die the same way. I want to make sure that I'm prepared, you know, thinking about my children. Can I know what was the treatment? You know, because if I get that same diagnosis, family history is the biggest indicator of how I'm going to respond to my particular treatment. So it's really important. What stage? What was the treatment? What type of breast cancer did it originate as?
How old were you when you got it?
Exactly. So that way you can start being screened 10 years, preferably prior to that first diagnosis that they're aware of in the family.
Well, yeah, I think that Dr. Hampton prescribes that you get a risk assessment at 25.
Mm,
But and you know, every Black woman should get a risk assessment so that you sit down, you talk about her story, you
yes.
talk about your genetics, you talk about,
Mhm.
you know, when you started, whatever, you know, you probably know what these factors are, but that helps you figure out when
Yeah.
you should go to get your first mammogram, because 40 is just too old for us. But
My
again,
health
all
system
this,
didn't even have anything for
oh
screening
yeah,
like that. They
yeah,
didn't have a mechanism for that until I got there 6 years ago, because
Mm,
you wouldn't get that sort of a risk
right.
assessment until you already got diagnosed with cancer. And then they said, oh, you meet criteria for genetic testing. And
wow.
so now we do it through our imaging center. When you come in to get your mammogram, even, or when you go into certain practices, and it'll hopefully be through all the practices, but they ask a really detailed family history about cancers, over 50, under 50. And then we crunch some numbers and we can come up with a score to know what your level of risk is, how high your risk is, so that we can know what screening you should be getting. But a lot of places are just starting to catch on to this. And if you're not getting this at your screening mammography, you know, your imaging center, I'm talking to people that's watching. If you're not getting this at your imaging center, you should be getting this at your gynecologist's office. If you're not getting it at your gynecologist's office, you can ask for it at your family practice office. Can you screen me for high risk? And there's
Mhm.
different models that they can use. One is called Gale. The other model is called the Tyrer-Cuzick model. And they put in the numbers into the computer, put in the family history. Did you have a biopsy before? Did you have normal cells or atypical cells? And they can tell you your risk.
Mhm.
Wow.
And I
Additionally,
mean,
yep.
But again,
it's
you
so
need,
important.
yeah, I was
And every
thinking,
woman should know her breast density too. And I think that we don't do
Yes, I was
enough
just about
job
to say that.
of see, we're here, man, of understanding what your density is. You get that letter in the mail and it just says
Yes.
heterogeneously dense
Mhm.
breast, you know, or extremely dense breast. And they
Yes.
don't tell you what to do with it, but they say this
Mhm.
thing: the sensitivity of mammography for detection of breast cancers is limited in the setting of heterogeneously dense or greater dense breasts.
right.
But our women know.
But
Right.
all these things though even start younger than that, and you know, we're starting from,
Right.
so that's why, you know, we have this HBCU program, because
Yeah.
every time we start an internship, we have the intern do a poll about what do you know about breast health, and
Mm,
the numbers are always less than 30%. They
yeah.
know
We got to
nothing.
publish that, Ricky. I'm
They've
telling you,
never,
it's coming.
and I think after we get like this next round, Mo, we should do
Mhm.
that.
Yep.
We're going to actually hopefully do like a webinar about what we've learned, but
Yeah.
it always starts under 30%, even when they've had breast cancer in the family,
Mm,
like an
yeah.
auntie or grandma or somebody had it. So, and the amount of young women who are doing self exams is
Yeah.
zero. They don't know
Mhm.
about it. They never talked about it. And so, you know, I think we should be talking about all the stuff in high school and middle school. And
Yes.
yeah,
That's why we visit schools.
yeah, so you visit schools, because even the whole clinical trial conversation about what is a trial,
Yes.
finding out about a clinical trial when you're metastatic is not the time to be learning about it.
Yes.
You have to have some frame of reference way before then. But
Mhm.
I think that, we have this great breast cancer choir. We have all of our breasties that are all informed. And if they don't know the answer to something, they can know who to call. They can call
Yeah.
someone. So, but we got to reach the women who don't have that.
Yes. When you think about the Chrysalis Initiative and who we support, none of them are familiar with this whole landscape
Yes, that's
of
what
breast
I'm trying to
cancer.
get to be. That's who you're reaching, and
Yes.
that's who needs this information and these
Mhm.
services so desperately because they don't have someone they can call. They don't
And
know.
once we're connected, we do introduce them to these areas because we do need more Black and Brown women involved in patient advocacy. But for the most part, these people are not familiar with all these organizations and support resources. And, they're finding the Chrysalis Initiative through social media and through platforms like this and through their health system and word of mouth, really. The new enrollees we received this week, they're meeting Black women with breast cancer like myself and saying, hey, you seem to be doing all right. What's going on? And then they learn about the Chrysalis Initiative.
So I love what you said though about taking these women from their fear into their confidence, right? And I'm paraphrasing, but basically, once they finish the program, and whatever finished looks like for them, because it's not always, to remission or to cure or to whatever, it's to a manageable state of life. So you can live your life to the fullest, no matter what your stage, what your diagnosis, right? But then turning them into ambassadors, turning them into advocates.
Where they want to be coaches.
Exactly.
They want to be advocates.
That's what I love about this model.
And you know what else is interesting? We find that it puts our doctors on notice. So because of the questions that they're asking, we find that, they're like, well, where are they getting their information from? I need to be on my P's and Q's and get it together. And they stand at attention. They're more attentive to these patients now.
Don't mess with us. Yeah.
Yes, exactly.
Yeah.
So I love it.
Great. That's so great. That's so great. But it's almost kind of like train the trainer. Like,
I know.
I tell two friends, you tell two friends. But that's the way it's got to happen. And thank God for that.
Because it's training a whole army. You know what I mean? When you think about
We're not having it.
Advocacy, and there really should be funding around an advocacy workforce. I think that that's something that we should look to as all of our organizations come together, because all of our organizations do advocacy training and education, right?
Yeah.
We train advocates, we train ambassadors, but then turning that into a workforce that can then be hired by health systems, that can be, that because I think that we have to stop doing the labor for free for these health systems.
Well, I think that also sets the Chrysalis Initiative apart because we pay our coaches. They're not volunteers, meaning we appreciate the value in their insight and the resources and information that they're providing to these patients. And if you think about just the cancer industry, how valuable that patient-centric and advocacy information and tapping into that insight is for the industry. So we demonstrate that we believe in equity across the board. So these Black women, these brown women that are providing this insight to patients, we pay them. It's not a volunteer type deal.
Yeah. I think that's
value.
But I think in 2 years and 5 years, health systems need to be paying these women, you know what I mean? In a really sustainable way. Like you might pay the first year or the first, however the compensation model is, but I think that value to the health systems needs to be quantified and it needs to be accounted for, because
it's a win-win, because with these pilots, their outcomes are better. The disparities are obliterated.
Yep.
It's like, to me, it's just common sense.
Yes, it is common sense to us, because we've been living with it our whole lives. But
the director of a cancer center, when I'll be quite honest with you that it is part of the indirect costs and downstream revenue that's hard to quantify. And so we got to speak the language of the bean counters and give them the beans to count that show direct return on investment. And as we get those numbers and that data, then you will see that metric move. You will see it change when you can tie the benefit of an advocate to talking to 5 patients to an X number of dollars saved by the health system. And it's sad that it has to be that way.
Each clinical trial, each health center, we're able to show how it actually produces cost savings when these outcomes are better.
Beautiful. So I've been keeping this running tab in the chat, Ricky, and I know you probably see it, but the people who are watching don't see it. And I'm trying to figure out, when we talk about what are because the title of this, right, is Disrupting Outcomes for Disparities. So what is the list where's the list of things, of actionable needs, items, demands from the healthcare systems, from our organizations, that people can take away from this so that they can begin to be disruptors themselves? What can they do?
Well, I think we have to start with just educating them on what they need to know and whatever tools are necessary to make that happen. But what would you think about doing like having a disrupting meeting and inviting the I don't know if it's the diversity and inclusion person in the hospital or whatever, sort of the whatever, somebody of power in these hospitals and organizations, and just convene a meeting. Let's talk about it. What's going on in your hospital? And how can we provide services to you to help train your people to do this work better? I think it has to be a big statement that we make. I mean, because even within the hospital setting, you have a lot of players that are all at different levels of how they think about this, right? So you may have the person at the top saying, "Oh yeah, because I'm getting paid to do this job," but
Right.
you may have 10 navigators that take a different stand with their patients, right?
Yeah.
So how do you deal with all that variability without like really digging deep and
Well, the way we've been addressing it is, of course, one health system at a time. And sometimes that in to the cancer center is who is that champion, right? That
Right.
appreciates the value of what we're doing, acknowledges that there's a problem and that status quo isn't acceptable anymore. Also, sometimes there isn't that person. And so we get that in and
Right.
that conversation by some other stakeholder that's involved. Potentially, we have board members of these health systems that are also able to kind of introduce us and provide that in for us. Funders, people that are in the community-based organizations that those cancer centers work with that can, okay, we want to address disparities. How are we addressing it? What are our current strategies? It's not meeting the mark. And more than likely, it's not meeting the mark because of these piecemeal solutions that we've been implementing
Right.
thus far. So why don't we use the Chrysalis initiative for this equity assessment and intervention and, move forward with this process, adopt the Chrysalis model, and actually have proven outcomes. And we're really focused one cancer center at a time, but we also already see down the pike what's coming. And I think also cancer centers, if you think about branding, how they want to be competitive, they don't want to appear as if they don't care about this. And actually it benefits them financially, just like with almost any other equity and inclusion and diversity investment, to their bottom line. So once we're able to demonstrate that, it then becomes an easier conversation as to why they should, incorporate us into their strategy when it comes to that. But we already have these guidelines that are in the pipeline as far as anti-racism in public health. Everybody wants to address this problem. And I think they're looking for evidence-based solutions instead of kind of just throwing spaghetti at the wall. And when I say throwing spaghetti at the wall, until there is that accountability where, it's not just, okay, pointing to these 5 things that we're doing, but meaning what is the post data set after this strategy has been implemented? So meaning what are the outcomes? If you're continuing to kind of operate in this space where we're applying what we can to it, but we don't expect anything to change, that's not, a solution. So I think it's, what is the evidence-based solution? And of course, the Chrysalis Initiative, we believe it's dealing with the systemic bias and racism. There are other areas that you need to tap into, but to us, those are just barriers that are part of cancer care, but it's not the root of the disparities. So you have to address the systemic bias and racism in the care setting. So meaning ensuring that Black patients can get quality care. So standard of care with the equity built in. How do you have those checks and balances and visibility in place? And our curriculum and model demonstrates that. So we just focus on one cancer center at a time, however that end is going to be.
That's how you have to start. And then hopefully you'll start to grow and be.
But I think that push is going to happen with policy. So with that change in policy, with the laws that are coming down the line, with anti-racism and public health, and these agencies to really have teeth to the accountability to make sure that this doesn't happen. And when I say patients be involved, be that patient advocate at the table, be part of that review board that's with the Cancer Center, get involved in some of the leadership. And again, I don't want to add more jobs to your plate because that is a lot, but even just getting your legislators involved, not knowing, most people are surprised when I do meet with legislators that this is even still an issue. But I think also what we learned from COVID is that these disparities exist and persist due to that systemic bias and racism that's not being addressed. And so I think acknowledging that this is an issue, it's not just circumstantial and it's not just something that you can't help, but you can ensure that these Black patients are not receiving harm and that you can have a spotlight on these areas to make sure that it just can't happen willy-nilly to these patients and there's no accountability for it.
I think it's some necessary trouble, as Sean Lewis said. You know, it's some good trouble and necessary. And many women at some point in their cancer journey, it may not be initially, but at some point are looking to help make sense of this, right? In the context of their lives and help it make meaning for women to come. And so we do see a lot of advocacy work, you know, through Komen and through others, through ACS, American Cancer Society, and they will have, you know, days on the Hill and things like that. But I think that you're providing a really powerful toolkit with what to advocate for and how to begin to encourage legislation to take shape in a way that is more equitable for Black and brown people. And like, that's the key, you know, because the legislation for breast cancer just trickles down and some people get it and some people don't reap the benefits of it, you know? And so we have to push for these things. Like, it's not enough, for example, to push for, you know, screening, for free screening mammograms or having mobile mammography units when if the only units that go to Black and brown communities are 2D units, right? And our breasts tend to be more dense. So what are we doing there, right?
And then what happens if there's a diagnosis? I need to have all those other diagnostic tests covered too.
Right. And so there's a lot to push for in terms of, you know, legislation and advocacy. And there is a role for every single survivor and thriver and metaviver and every single person who wants to get involved in this. And I think that's a huge takeaway.
Right. I think also, you guys, our best advocates are new patients that have either get in the middle of their treatment or sort of coming out of treatment. And then they you know, okay, I got to pay this forward. I've got, you know, got to give back. And that's how we've all gotten into it because, right? We had to say, okay, because this is not right. This didn't work for us. So how are we going to make it work? But you guys, I got to tell you the story, okay? And it's an example of what we're dealing with. So I was talking to this white oncologist in my doc's office. I've become close to my oncologist, of course, but and my doc is Hispanic, but he had a white doctor there, and I just asked him point blank. I said, "Do you offer clinical trials to your Black patients?" And he said, "I don't. I rarely do." And I said, "Why?" You know, like I'm like, Steve, come out of here. He said, "Because they won't trust me." He said that I've worked really hard to gain their trust, and I know they have issues with trust. And he had all good intentions in his head, but his answer was, if I approach them and ask them about a trial, I could lose their trust, and they won't keep me as their doctor. I said, does that sound like backwards to you? Like when you really think that through? And I mean, but he was convicted about that he felt like he was protecting his patients by not offering trials to them. Because he didn't want to lose their trust. Now,
we call that paternalism.
How about we want to keep their life?
Right.
I have seen and I have read, there's a great segment on NPR where a woman who was diagnosed with an aggressive form of breast cancer, she's a former educator, went to the NCI designated cancer center, and they told her what she needed, aggressive chemo, this, that, et cetera. And then she went to the community hospital because she lived closer. She wanted to see what they would say. And that doctor said, "Are you married?" And she said, "Well, no, but I have." He said, "Oh, you don't have a husband?" And she said, "Well, no," but he says, "Oh, well, you may want to consider these things and these regimens and da, da, da." And, you know, she said, "But I have neighbors and I have a church family and I have my cousins live nearby and I have support." He's like, no, this is too hard. This is too much for you. And offered her less than the more aggressive standard of care regimen. And she was a retired professor. And she said, "I could not believe that, you know, it would have been better if he had meant ill of it, but he really
Yeah.
thought
No.
that his
Mhm.
paternalism was protecting me. He
Right.
thought he
Yes.
was doing something to help me.
Yeah. And so we
That's
teach
fair.
about, these white paternalistic doctors, or even some of the folks that have the white savior complex, where, they're exhibiting that bias in
Right.
care just due to assumptions. That's not
Sometimes they're
valid.
black. Sometimes they're black
That
and
too.
brown. And this is why
Right.
it's important to do things like that
Drinking the
implicit association
Kool-Aid.
test, because
Yes.
you'll find that it's not just being white, it's black. I
Yeah.
don't want to lose
They're
the trust of my
subscribing to the same
patients if I
system.
start saying these things, right?
Yeah.
And they're doing it too for a different reason.
Yeah.
But that bias is still as pervasive, man.
Mm-hmm. Where we get that a lot, where Black-led cancer centers are saying, well, they have the same assumptions about Black women and the attitude and hostile, and they're not going to adhere to this trial. So why would I even bother giving them this information?
Mhm.
So yeah,
Scary.
subscribing and I call that drinking the Kool-Aid,
Yeah,
but
yeah.
bias can come in all forms. So I think it's a disservice.
Mhm.
I saw a recent quote where it's a disservice to say that only white people are responsible for this white supremacy structure that we have. We also have,
Yeah.
supporters of it
Mhm.
that are abetting and aiding, and that's Black people included. So yeah.
Mhm. It's
So
true.
Jamil, when should someone call you? When should someone reach out to the Chrysalis Initiative? When should someone, and when should they, when can you can help them from day one. So,
Yeah. Yeah.
and we're going to help you get the word out so people know that you're there. That's all of our job.
Yes.
We'll all do
Thank
that
you.
together.
I appreciate that.
Like, when do I call you? When I get sick, when I get diagnosed, or do I have to have an experience that I know is not right? Or, like,
Anytime, if you're diagnosed, or even if you're not diagnosed yet, you might have history in your family, or you're a Black woman that equity is important to you, or you could be a white. We coach all races, all stages, all ages. And so even if just health equity is important to you, whether or not if you have a condition or breast cancer or not, if it's just equity is important to you and you want to connect with us, find us on social media. We're on Facebook, Instagram, and Twitter. Check out our website. We do have a lot of programming for people that are pre-diagnosed. So again, don't have a breast cancer diagnosis, but want to get involved, or if you just want to be a supporter, we have a calendar of events where you can, learn, connect, get involved. We're going to start adding educational content to the website. So we're really excited, and just continue to amplify and share, because everybody knows someone that can benefit from this type of. So to have a coach, meaning you're either a caregiver who knows someone with breast cancer that you want to support. So we also have caregiver coaches. And then there's also, if you have a diagnosis of breast cancer and you need, no matter where you are, so meaning you could be newly diagnosed, or you could be further along and you just want to make sure that actually you might be able to benefit from the Chrysalis coaching model and care tracker, where you have somebody that pretty much has a stake and is connected to you and rooting for you, to make sure that you know everything that you need to. Or you could be a patient and you're like, you know what, I want to either be a coach. I've been impacted by breast cancer. I believe I have a lot of knowledge to share. Or, we sponsor patient advocacy projects. So we work with you, train you on systemic bias and racism, or connect you with those opportunities, like with Susan G. Komen, with Living Beyond Breast Cancer, with Project Lead, NBCC, NBC Angels with Tiger Lily, connecting, Black and Brown women to clinical trial projects if they're interested in research, or getting involved in policy advocacy, because we need more of us represented in these spaces. And so, yep, it's all across the board. And if you are working in a care center, in a cancer center, or involved in a clinical trial, yep, definitely utilize us as a resource, because we're going to ensure that your patients are protected, or we can provide you with solutions to ensure that racism and bias is not interfering with the care that you want to deliver. We have a lot of really great cancer centers that have the best intentions, but all of that investment, all of that work can just be undermined by just one racist bad actor that's exhibiting bias to a patient and causing harm to them. To me, that's riskier than, yeah, that's just too risky to have that within your center, based off of what you're trying to establish as far as your care delivery.
Yeah.
So
Jamil,
finding a coach. Sorry, go ahead. Go ahead,
no,
Ricky.
I want people to know what a big impact she's making in such a little
A little
time.
bit.
So talk about the numbers that you told me. Like
Oh, wow.
you're like a badass. I mean, and you just started this a few months ago, and
Right.
you've touched a lot of people. So say it, brag it, put it out there.
Well, I mean, I've been, I was diagnosed in 2018. I launched this on my own, just personally, not thinking with metastatic breast cancer,
Right.
I would launch a full-on nonprofit. But working with so many other organizations and people knowing me, and I think with launching the nonprofit and being on social media, and people seeing the website and connecting with us, we're now growing. We're up to 25 coaches in 14 states. Our goal is to reach, those states with the highest disparities. And we have 500 women, all stages, all races, all ages, that have a coach and are receiving that ongoing, connection and counseling and navigation support in their breast cancer care. And so we're trying to grow more.
Go grow. That's amazing.
You will grow. And the
Okay.
model that you've developed is such a sustainable one, when I think about what I see for the future of this organization, because I'm so proud to be a part of both Touch and
I know, I text you all the time.
feel free. You keep it coming. I'm here for it. It's time to make some waves. But what I see is I see us being able to plug in this very educated, powerful, unashamed, unafraid group of ambassadors into seats at the table at cancer centers all across the country, right?
Yeah.
So now you can strategically train somebody and then place them on a committee, on a board, in the room where certain things are happening to influence cancer care. And if you're basically educating a workforce, right?
Yeah. And we're saying status quo, we're done with that.
Yep.
Yes.
Yep.
Done with it.
Yeah.
Agreed.
Oh, it does not work. It's not working.
No. Mm-mm.
Wow.
Can it? Wow.
Incredible.
So come connect with us, thechrysalinitiative.org.
Spell it. Spell it for people. Spell it for the 6-year-olds.
Spell the Chrysalis Initiative?
Yeah, we'll put it in the chat and the link and everything. But
I'm already putting it in .org.
Okay.
www.chrysalisinitiative.org.
So Chrysalis, CHRYSALIS, initiative, INITIATIBE.org.
Done. Chrysalis Initiative.
what does it mean, real quick? I love this.
I don't think she heard you.
Yeah.
What does it mean?
What does it mean?
Oh, well, when I was thinking about my own personal experience, I think that, the whole point of the chrysalis, that's that period of transformation where you're, wrapped. It's that transformation from the caterpillar to the butterfly. So when you go through when you have a breast cancer diagnosis, your life is not going to be the same. That is true. But because of that transformation that you're going through, and the fact that we're going to envelop you, we're going to reinforce you, we're going to make sure that you're cared for, and you could get that best treatment as you're going through that transformation, you're going to be able to experience that beauty on the other side. And so it's basically a nice way to say we've got you. It's a chrysalis to envelop you and wrap you up with care.
And it isn't always comfortable. Sometimes it's dark and it's confusing. And
definitely some transformation.
And it doesn't feel good, but there's transformation on the other side of it.
But I think about, my own experience. Yeah, I would say, the reason why I'm able to be a disruptor is because when you have cancer, even metastatic cancer, I'm really thoughtful and intentional about how I spend my time and who I spend my time with and what I'm doing. And so I'm constantly thinking about the legacy that I'm leaving for my family and trying to learn and do as much as I can to be here for them. But at the same time, just thinking about, the status quo type activities is just not going to do it. If you keep telling me that Black women just have to die at this rate and there's nothing we can do about it, but actually, no, there is something we can do about it. How about we get the racism out the way?
Right. And get the care in the way.
Exactly. Empowering patients. That's what we're doing.
Yes.
Empowering Black women.
Disrupting the ecosystem to empower.
Disrupting. I love it.
Yes.
That's
And
right.
listen to Black women.
Right.
Mhm.
Pay us, fund us, listen.
Listen,
All right.
save us.
Yes. Mm-hmm.
Well,
Thank you so much.
Thank you.
Love
I
you so
appreciate
much.
it. Love you too. I appreciate both of you.
well, much work to be done. And I think we'll talk more this month about healthcare disparities and disruption and continue to drive the point home about education before cancer diagnosis as much as we can and fortifying that pipeline, you know. We hope this has been relatable and reliable and real.
Yes.
That's what we set out to do every single Wednesday night for the last year.
Yes.
Aw,
I know.
appreciate you guys.
It's my birthday, Mo.
Happy birthday, happy anniversary, Ricky. It's been my
Anniversary.
pleasure.
Oh, wow.
do
You know, this
what
is
you
my
do.
birthday month.
Is it really? That's
Yeah.
Happy
April
birthday.
20th.
Wow. If
I
you would like
celebrate
to,
every day, the
that's
whole month.
right. That's right. For
And
people
I'm
who are watching,
I'm
Mhm.
celebrating 2 years of no evidence of disease and clear scans.
Woo!
So I got
fantastic.
my scans yesterday.
Oh, you go. That's awesome.
Fantastic. What a
I know.
blessing.
Thank
Good
you.
birthday month.
We got to celebrate.
What's up?
Yes.
What's the party? What's the party?
Dance party.
Dance party. Well, we'll be
Love it.
dancing on Friday, you know, Friday, 3 o'clock. Every Friday, 3 o'clock, we dance. Next week, Mo, we're gonna talk about what's her story and talk
Okay.
about genetics. And then the next week after that, we're gonna talk about stress.
All
So
right.
what we start the show with today. So
I love
we
it.
have lots to talk about, during this Disparities Month and
Mhm.
you know,
Yep.
keep that breasty love going. Thank you,
Absolutely.
Allison.
Yeah. We got to dedicate this show to Allison. We love you.
Allison, we love you, Allison. You know, Allison's having a rough time, and we just want you to be peaceful and floating.
No pain.
No
pain.
pain.
We love you.
We love you, and she's been with us all along, and she will be.
That's right.
Mhm.
Absolutely amplified. All right, gang. Take good care of yourselves. We will see you next Wednesday night. The doctor is in. Resty love. There it is.
Thank you.
See you.
See you.